medical terms we call morbidity, but they have very high rates of mortality. These are killers. Now, they're not killers in the sense that maybe these cancer, heart disease, and stroke would be killers. But they're killers in the sense that they, in two ways really. One is a very high rate of suicide. If I ask you, just as a spot question, in this country, more deaths from suicide or homicide, what would you say? Suicide, yeah. Numbers, 35,000 suicides in a year in the United States, about 18,000 homicides. You wouldn't think that from reading the paper or listening to the news, but because we always hear about the homicides. But actually, suicide is almost twice as common. We think that somewhere up to about 90% of suicides involve a serious mental illness, sometimes depression, often schizophrenia, often in younger people, but not always. That 35,000 number, just again, to give you some context, is not only almost double the number of homicides, it's actually more than the number of traffic fatalities in America. And it's an important reference point because that wasn't always true. For a long time, we were looking at somewhere between around 40,000 homicides and about 45 or 50,000 traffic fatalities every year in the United States. And those numbers have come down in a very profound way. The number of suicides is actually pretty much unchanged over the last 2 decades. We haven't been able to budge those numbers. And one could say, no wonder. We have a whole criminal justice system to reduce the rate of homicide. We have an entire national safety program to reduce the rate of traffic fatalities. What are we doing? What are we doing to reduce the rates of suicide? And that's a fair question because we don't know as much about what the seatbelts would be, what would be the right ways of doing that. But again, it's a question that I think bears a very active and very thoughtful public discussion. It's happening now. That discussion is happening of all places, in the U.S. Army, because the Army is losing more soldiers to suicide than they are to combat. And that wasn't always true, but it's become true in the last 2 years. The rate of suicide has doubled in the Army. And they care deeply about this. It's, again, not only has the rate doubled, it may be leveling off in the last 3 to 4 months, but they're at a point where they lost 160 soldiers to suicide. Last year, if you add National Guard and others, it goes up to well over 250. The National Guard suicide rate went up, we think, about 50% or over 50% just in the past year. So there's great concern in the Army about what are the drivers, how do we detect this, how do we bend the curve here? And of course, this is not just an issue for active duty soldiers, but an issue for the veterans when they come back, and for people who aren't necessarily under the jurisdiction of military medical care, which is pretty good, but maybe out in the community and either aren't connected to the VA or aren't thinking about or aren't able to get the kinds of care that they might need. One last thing about this idea of mortality is to realize that aside from the suicide rate, that people with serious mental illness, and here we're talking about with schizophrenia or with severe depression, bipolar illness, have a life expectancy. This is an amazing statistic to me. The life expectancy in the United States is about 55, so they die about 20, 25 years earlier than they should. It's exactly the life expectancy today in Bangladesh for people without mental illness. But that tells you something about the disparities in care. And that early, the shorter life expectancy that the two decades lost, actually 2.5 decades lost, isn't really due to suicide. It's due to mostly pulmonary disease, cardiovascular disease. 44% of all cigarettes smoked in the United States are smoked by people with serious mental illness, that 4 or 5 or 6% of the population. And so they get very high rates of emphysema and pulmonary disease. So this is not just a problem of mental a mental disorder, it becomes a problem of physical illnesses, it becomes an economic problem for the nation. And most of all, and this is where I really want to take our conversation, and I'll end here, is it becomes, I think, a moral problem. It becomes a problem of civil rights. It becomes a social justice issue. These are the people in this country who actually are the most isolated, the most, in many ways, disadvantaged, and those without a voice. It's hard for us to realize that there could be, in this case, several million people living in the United States, many of whom were born with means, were born into very wealthy, very successful families, who, because of having a particular kind of brain illness, find themselves homeless, without insurance, and because many places will not provide insurance to those with serious mental illness, they are basically on the outside of getting care. They are 3 times more likely, when they get sick, to end up in the criminal justice system than the healthcare system. 3 times more likely. So this has been a problem that has actually, not only have we failed to understand that these are brain illnesses, America increasingly fails to understand that these are even illnesses, and they are increasingly incarcerated and sort of criminalized instead of treated. Now, some of this has to do, as we saw last week, with people who don't realize that they have an illness and haven't come for care, as far as we know. But even those who do, particularly if they are people of color, are likely to end up in jail and not in a hospital. We do have treatments. We have treatments for most of the forms of serious mental illness. They're not perfect, they're not great, but they work pretty well for a lot of people. But access is the problem. And access is a problem because of many reasons, not the least of which is that much of the healthcare system that we provide for those with serious mental illness is either not affordable, it's not easy for people to, we don't have that kind of community mental health network that we once had. And to be fair, many people with these illnesses are in a state of hopelessness so that they don't want to navigate the difficulties of getting access, even when that might have been possible. I tell you all this because I think we're at a point in time which, to me, is really poignant in a sense. You see what's happening in terms of the financial crisis that's facing every state in the country. And as Frank Rich mentioned this morning in the New York Times, one of the first things they're going after is support for those with serious mental illness, and because it's a population that has no voice. It's an easy target. Nobody's going to scream. These people are homeless. They're dysfunctional. They can't get up and scream because they can't even get out of bed in some cases if they have severe depression, or if they're psychotic and schizophrenic. They may not be able to have the kind of cognitive wherewithal to be able to fight for themselves. So it's going to get worse, not better. At the very time when we're in the middle of a revolution in the way we think about these problems scientifically, at the very time when we have the capacity, actually, to make the most progress, to be helpful. So all of this reminded me, given that this is January 16th, the day after Martin Luther King's birthday, of a speech that he gave, a sermon actually. It was the last sermon that he gave it was here in Washington at the National Cathedral, March 31st, 1968, just about 10 days before he was assassinated. And I'm going to close with this because I think it's, in an odd way, it's actually highly relevant to where we find ourselves when we think about the problem of how we're going through this revolution on the brain, and yet it's not been able yet to revolutionize the way we help people with serious mental illness. The name of the sermon was called Remaining Awake Through a Great Revolution. And Dr. King at that point, looking around the room, most of you are of my generation, and so you will remember that at the end of his life, he was one of the most reviled people in America, both by the African American community, which found him irrelevant at that point, and increasingly even by those of us in the anti-war community who found him just out of step. So this is even more poignant. He was invited to give this sermon at the National Cathedral, and he starts off by saying that how delighted he is just to be given this opportunity because no one's listening to him anymore. And it makes, it's an important moment for him to be able to have an audience, particularly in Washington. And then he says fairly quickly, he says, "I'm sure that most of you have read that arresting little story from the pen of Washington Irving entitled Rip Van Winkle. The one thing that we usually remember about the story is that Rip Van Winkle slept 20 years. But there is another point in that little story that is almost completely overlooked. It was the sign in the end from which Rip went up in the mountain for his long sleep. When Rip Van Winkle went up into the mountain, the sign had a picture of King George III of England. When he came down 20 years later, the sign had a picture of George Washington, the first president of the United States. When Rip Van Winkle looked up at the picture of George Washington and looking at the picture, he was amazed. He was completely lost. He knew not who he was. And this reveals to us that the most striking thing about the story of Rip Van Winkle is not merely that Rip slept 20 years, but that he slept through a revolution. While he was peacefully snoring up in the mountain, a revolution was taking place that at points would change the course of history. And Rip knew nothing about it. He was asleep. Yes, he slept through a revolution, and one of the great liabilities of life is that all too many people find themselves living amid a great period of social change, and yet they fail to develop the new attitudes, the new mental responses that the situation demands. They end up sleeping through a revolution and missing an opportunity of a lifetime. And I wanted to say, particularly with George sitting behind me here, that I think that one of the things that George has done in creating a group like this and bringing in scientists who are really on the edge of this revolution, from Francis Collins and Kay Jamison and Alan Leshner and many others who have participated, is that it does make sure that at least a small group of people are remaining awake at a time when science, I think, really has an opportunity to change the way we think and the way we behave. Thank you very much.